human experience of care. To guide us, we are joined by a true titan in our field. Professor Alison Fox Robichaud, I believe the correct pronunciation, is a professor of medicine, the Hamilton Health Science Chair in Sepsis Research at Manchester University, and a critical care medicine specialist. She's the head of service of critical care response team and director of medical education at Hamilton Health Sciences. She's the scientific director of Sepsis Canada. She has over 180 peer-reviewed publications reflecting broad academic interests, including animal models of sepsis, translational medicine, health services, research, clinical practice. A leader in the critical care community. She was the first female president of the Canadian Society and the first female chair of the Canadian Critical Care Examination Board. Internationally, a member of Global Science, the advisory board of the International Society for Response, the club of Critical Care. She was the organizing chair of the very successful World Congress was concluded in September in Vancouver. She has been honored nationally for her work in electronic warning source prevention and medal for the National Sepsis Leadership. Internationally, in 2018, she received the Global Sepsis Alliance Award as an individual for sepsis leadership. It is therefore my great pleasure to invite Professor Alison Fox of withholding and withdrawing care. You are welcome. Thank you. You can share your slide. Professor Alison.
Good evening, everybody. My sincerest apologies. I'm just going to get this in presenter mode. I want to make sure everybody can see can you see my screen? Irene, just give me a little help. Are we seeing my presenter mode?
We can see your screen.
Yes, we can. I can.
Okay, now can you, and it's in the correct view, correct? It's not in presenter view.
Yes, it's the correct view, yes.
Thank you. My sincerest apologies. This is not used to giving talks on a Sunday afternoon, so I completely skipped my calendar. But what I'm going to do over the next 15-20 minutes is really talk about end-of-life decision-making, put some ethics in, and maybe a bit of a Canadian perspective to it all. I always like to start by acknowledging that in Canada, I live in the province of Ontario, which has been the traditional territory of many nations. And for thousands of years before we settled on this land, the first people sought to walk gently. They offered assistance to European travelers and sharing their knowledge for survival in what was at times a harsh climate. And we, as settlers on this land, build new relationships with our Indigenous peoples and guide by the care and right actions that we transform our personal and institutional relationships. And speaking to colleagues in Nigeria this afternoon, I think you recognize some of the aspects that colonization may have had on your culture as well. So what I want to really do is talk about our end-of-life policy, including some of the history behind these changes. We have some support for programs and families to navigate that, and we can talk a little bit about this. But I also want to integrate this knowledge into end-of-life policies that you may interact in your hospital, discuss how it impacts in your role in critical care. I'm not sure if anybody's ever read this book. This is a book written by one of my mentees. His name is Blair Bigham. Blair trained in emergency medicine and critical care. He spent some time in your parts of the world. But when Blair was doing his critical care training in California, he flew back and forth between Toronto and California and really started to think about how medicine complicates the way we die. And Blair's background was not only emergency medicine and critical care, but he was a paramedic before he went on that. The picture where you see him is on the top of the hospital where we are. And Blair had this dilemma that he created, that we sometimes have this dilemma between the patient's wishes. I'm going to use a new term that may be different for some people, substitute decision maker. It's our formal term for family members. And we have some legal documents associated with that. And the team that's providing healthcare. And the other thing that Blair does is he talks about all of the technology that we use in critical care. And I don't know about Nigeria, but in North America, there's a lot of television programs that somebody gets CPR and 100% of people survive that. And we also have a bit of a culture that talks about the fact that death is not an endpoint for all of us. And so it often leads to this belief that our technology, combined with the belief that doctors and nurses can do anything and we're not going to die, leads to a false hope around end of life. And so our college in Ontario really has struggled with this. And I'm going to kind of bring that framework into our latest policy that sits within our college. And I won't say it's universal across Canada, but sits within our college that really defines, first of all, what is resuscitation. And if we define resuscitation, the things that we do as ICU doctors or emerge doctors or other people like that, as a suite of medical interventions, that is, whether we provide chest compressions, whether we provide mechanical ventilation, whether we defibrillate, whether we intubate somebody that may be provided following a cardiac arrest or a respiratory arrest in an attempt to get or maintain cardiac, pulmonary, or circulatory function. And not all of these interventions will be necessary or required in all cases. And so with that policy was a lot of work behind it, but it becomes a decision about what is resuscitation. And then the next question you need to ask is, when is resuscitation not standard of care? Okay. When are the things that we do for resuscitation not standard of care? And when I teach the residents about this, I often talk about that physiology. Resuscitation may not be standard of care when physiologically any amount of CPR or mechanical ventilation will not provide oxygenated blood to the brain or to the heart, right? The heart's been stopped for a period of time. The brain has no blood flow. That is when physiology says, no amount of resuscitation is going to fix any of those problems. The second one is maybe a little more difficult to think about, where resuscitation will not treat the underlying progressive end-stage illness or complications. That is, we have done everything we can. But for example, the example we often use here is end-stage heart disease or end-stage lung disease or end-stage metastatic cancer as examples of where resuscitation and the prognosis of the underlying condition, no amount of resuscitation is going to change that trajectory. And finally, proportionality. The things we do are very invasive and they may not have benefit. And this is where ethically, we sometimes have to check our biases to say, can I turn this patient around? Or may it not have any benefit? And as we understand critical care more and the complications of critical care, I think we need to build that proportionality into resuscitation. And then finally, resuscitation is not a treatment for ordinary dying. And I like to use this example with the residents about Queen Elizabeth II's death. And the fact that she was one of the wealthiest women in the world, and yet she chose to die at her home, family around, and at 95, and she had had a good life, right? And so all of the things that we talk about, resuscitation or maintaining mechanical ventilation, are not the treatment for ordinary dying. The article on the right is a link to an ethicist from the UK, Catherine Mannix, who talks about this ordinary dying and how it pulls this idea that when we reach our end of life, resuscitation may not be to our benefit. Okay. Now I'm going to bring in a little bit of Ontario law. So we have this legal document in our home province. It only applies to 40% of Canadians. It doesn't apply to everybody across the country. But it's called the Healthcare Consent Act. And it assumes three things. It assumes that persons have a capacity, right? It assumes, and we have a real big hierarchy of who is that substitute decision maker, whether it's somebody who carries legal guardianship, whether it's a spouse, whether it's a child of the person whom we're talking about, and that all treatments that we provide require consent that is time perspective. And then it went on to define treatment as anything that is done for a therapeutic, diagnostic, cosmetic, or health-related purpose, okay? And what happened in my part of the world is it led to a lot of conflict. It ended up challenging the way we provided care, okay? And what happened, and I was just coming into leadership in the society for a while, is that we ended up with a previous policy that caused a whole lot of disagreement. And so Irene and I have, as we've been talking to you as critical care providers in Nigeria, talking about what you do and do not have, I would say this is not always the way to go, but the policy for us at our regulatory college made a lot of difference in terms of where we've gotten to in the end. But what happened was, if the patient disagreed with the healthcare team and insisted that we had to provide cardiopulmonary resuscitation, then the physicians had to engage in a process of conflict resolution, and we had processes associated with that. And that while conflict resolution was there undergoing, we actually had to provide CPR and do it in good faith. And so it led to a lot of conflict where physicians particularly felt they were moral distress, but certainly the entire healthcare team said, why are we doing this for somebody where care might in fact be futile and we're only going to cause them more harm? Back to that proportionality piece. And so the consequences of this 2015 policy was that we could, the substitute decision maker, that loved one at the side of the bed, could actually compel the physician team to do CPR, even if there was no physiological rationale. We weren't going to fix anything. They might actually contradict the patient's wishes. So the patient might say, I don't want to be intubated. I don't want to be given CPR. And then they're no longer competent to make those decisions. And the substitute decision maker would come along and say, of course, you're going to do this. And it didn't give us a guidance on how long to do that. And it really had an impact on how we provided care. And eventually, it actually went through our court system. It went through our court system.
Hello? Can you hear me?
Yes, we can hear you, but it's lost. Dr. Irene, can you check what's going on?
Okay, let me find out. No, we can't hear you.
Seems speaker had network issues. Let's just be patient.
She's muted. She's muted. That's all.
You can share the slides again.
Yeah, I'll
Okay.
share the slides. Okay, can everybody hear me again?
Yes.
Okay, good. Let's just get ourselves back on again. Share my slides. Share my slides. There we go. Sharing again. My apologies. This has been a comedy of errors today. Okay, and let's start with this one. Okay, come on. There we go. All right. Irene, is this where I was talking about the new policy before I dropped off?
Yes,
Everybody
ma'am,
can
that's
hear
where you were.
Yes. I think
Thank
so,
you.
Dr. Harrison. Okay.
Okay, we're good. Back on track. This has really been comedy of errors, but let's get back on track. So we had a new policy. It was 8 years since the last one. We had already made this court decision that it was not appropriate to that withholding life-sustaining measures, resuscitation measures, was no longer treatment within the province of Ontario. So that's where we were. And the new policy set out 4 directions. And this is where my conversations with Irene, I think this may in fact be beneficial, but whether it's going to stand the legal test in Nigeria is a question. Okay. So we'll work our way through each of these things, but I'm going to talk about withdrawing life-sustaining therapy particularly. Okay. So here's what we know within withdrawing life-sustaining therapy. First of all, the policy sets out that we must get consent for withdrawing life-sustaining therapy. This came from on Canadian Supreme Court decision called Razuli versus Cuthbertson, and somebody will recognize that name, Cuthbertson. That is our dear colleague here in Toronto, Brian Cuthbertson. And what it said was that the withdrawal of life-sustaining therapy, that is, you already have somebody on mechanical ventilation, and to a certain extent it's being challenged, even vasopressors these days, you must obtain consent for taking them off the ventilator. You must explain why it's appropriate. The backup plan is that we actually have a board as part of that Consent Act who will deal with conflicts when they arise. And having recently done that for somebody who was in a vegetative state for 8 months, I will say the process is rigorous. Families still don't often agree at the end of that, but it's legally binding. And so before applying to that, we have to go through a series of things, including an ethics board, to be able to do that. And it really says that the duties of the substitute decision maker are to listen to the healthcare team and to ascertain what the patient wants. So in this example that I have recently, where this man was in a vegetative state for every month, the family could not say that he actually explicitly wrote out on a piece of paper or said to any of his family members that he wanted to be left in a vegetative state for the rest of his life. And so that's where the disagreements. And I will say that in Canada's more secular society, while faith-based issues come into play, they are not held necessarily to the same extent as they might be in other countries. And we can have a conversation about that afterwards. Okay. Withholding resuscitation measures, however, is not treatment and therefore does not require consent. And so when the risk of harm outweighs the benefit of providing resuscitation, we could write orders that says we don't have to do CPR or other things. But we have some things we must do. You still have to consider the wishes, the cultural, the spiritual values, the beliefs, and they must inform that patient or the substitute decision maker before. They've got to communicate diagnosis and prognosis and why it's not appropriate and provide alternative treatments. There are certain situations we all know where that deterioration is very rapid and imminent, and we can write that order, but we have to explain to the families afterwards why we didn't provide full resuscitation. And then managing disagreements, really, we have a lot of ethicists around, so we use ethicists. We got to clarify prognosis, identify gaps, reassure patients that spiritual care will be provided, emotional support will be there, and use second opinions. And I think that's one of the things in this is really thinking about second opinions. And so if I pull all of this together, when people are deciding about resuscitative measures, I would be very curious about this piece. Before people even hit the door, are there conversations amongst families to prepare for the what ifs, I like to say? What if it happens if I get sick? What happens if I'm not doing well? And come to a shared decision making. And this may be a Canadian phenomenon. I will love to learn about what happens in Nigeria. But really thinking about whether patients do or do not want, and then writing the orders for that. More acutely, we talk about this as goals of care. When we urgently need a decision, and what is the standard of care? What are the proposed treatments? When we got this final end of life policy through the college, we really akined it to what a surgeon will say. Surgeons will say that sometimes operating on this patient is too risky or not beneficial, and they have the right to say, we're not going to do that. Similarly, what we have said to the colleges, intensive care physicians, emergency medicine physicians who have to provide resuscitation, it's the same thing. We don't have to provide things that we don't think are standard of care and what we think will be beneficial. And we can still write this order to withhold resuscitative treatment and use all of those other supports in place. And with that, I'm actually going to end the slideshow and stop sharing and open it up for questions. Hopefully get us back on track a little bit.
Thank you, Professor Alison, for sharing with us your experience down there and then highlighting us on possible what we can do. We appreciated that. Now, the chat is open for any questions to give us better insight and understanding and how unique it is to our own environment. You can raise your hands and we will allow you to ask questions directly, or you can just place it on the chat there. I have, let me say, Prof, you shared more on your policies down there, the experience, and how the legal team have prepared the ground to make it a soft landing for practitioners and physicians. What would you advise in our own environment where physicians and critical care specialists usually have different opinions? Example, an 80-year-old patient that is on his way out. All signs are showing, all organ failures are all in place. And these physicians now consider, oh, there's somewhere where the magic happens, the ICU. Send consults, let the patient come to ICU. Where does this critical care physician, what happens to him? Because if you say no, you may enter challenges with hospital management. What would be your own advice to issues like this?
I would say this is where we know our environment best, and being honest about using a few words, using the word dying. I had one of my colleagues who say, we don't use that word enough. You are dying. And so not being afraid of that word, being frank. There used to be this culture about not talking about how potentially harmful CPR is, or how potentially harmful mechanical ventilation is. And even though our policy says it's not treatment, we don't need consent to withhold it, we still have an obligation, I feel, to explain as clearly as possible, same as a surgeon would explain surgery, what happens when we come into an ICU. We take away your ability to speak because your tube is past your, vocal cords. We may have to hold you down or give you medications so you can't interact with your family. And so this is where I think the first step comes, that as critical care physicians, you need consensus on what we can and cannot do, right? And I think this is where the policy that we've got in Ontario actually gives us a little bit of agreement, because when the first of the troubles that we had in 2015 after the Consent Act came out from the government was they hadn't consulted critical care physicians. And so this is where we started into those troubles. And I think by going through this process over the subsequent 8 years, you realized that the critical care community was united in not providing futile care, not providing care that we knew was not going to change trajectory and only make the dying process more uncomfortable and painful. I see a couple of questions in the audience. So let's talk about the cost issue. So in Canada, cost is the one piece of ethics that is rarely discussed. We have a universal healthcare system. Anybody can get access to they don't get a bill at the end of the day. It doesn't matter what the resources are, we can provide it. Do we talk about it? Yes. Do we occasionally have families where we are absolutely sure that the reason they do not want to withdraw life support is because there is a pension or some sort of income coming in? Absolutely. But it is unfortunately in our culture something that's not discussed. I know in your payer system in Nigeria, cost absolutely becomes, and if you talk about in the US of A, where people can become bankrupt because they've put people through an ICU journey. I think that's an important conversation to have. The next question, when there was no prior and the patient, what is the most important step for the critical care physician? So no prior DNR, family says, oh no, of course you're going to do this. This is where that patient autonomy part of ethics, I think, really comes in. Your loved one said that they did not want this. And this is where we went back through this journey because families were overriding this. And ultimately, it's that person in the bed who knows what they do and do not want. And so this is where I think patient autonomy comes into it to a certain extent, right? We can't provide, there are things we just aren't capable of doing. But I think that it is absolutely appropriate. Okay, when there's a DNR, what does it entail giving drugs and the medication? So what is it all about? So I think the other thing that came out of this, when we have consent or we have a hearing that says we can withdraw life support on a ventilator, we do have a standardized approach. Some of that has come out of our donation work, but it is low dose bolusing, infusions of opioids, infusions of benzodiazepines or propofol. We tend to use both. It's clear orders to whoever's withdrawing the mechanical ventilation to make sure the patient is comfortable. So we do have a critical order on there. I got to go back up. Okay. When there's a DNR, can orders like, okay, so at our hospital, yes. So you can have, and we call it a scope of treatment order. So you can have no CPR, no mechanical ventilation, no even non-invasive ventilation, but you could still be given continuous infusions of vasopressors, right? And so we will often get elderly patients in our ICU who might be on oxygen, might be on high flow, but are just getting over another episode of sepsis. And so they're having that infused and and I used to get grumpy about that and really say, well, is that within their goals of care? But I'm starting to realize that we can turn people around quickly with a short course of antibiotics, let the antibiotics kick in, and then use vasopressors. So do not resuscitate in the setting of CPR means no adrenaline. But in the ICU setting, a scope of treatment may include vasopressors only, but no mechanical ventilation, maybe not even non-invasive. Harrison, I'm still going through these chat. I hope that's useful. Let's talk about the next one. Okay. Thank you. Can the similar level of care and or similar potential outcome be portionable for a patient and disproportionable for another? So, limited resource. Would you advise policymakers regarding escalation conversations leading to all? So I think the first principle for this question, Julio, is really this. What does the patient want? And it may be that a person with mild, let's say, cardiovascular disease, had an MI, or even a cancer would have said, you know what, I don't ever want to be in an ICU. I saw my parent go through a hard ICU journey, or in your case, financially, I can't support that. I just want to be with my family at the end of life. Whereas another person may want to say, you know what, I'm going to give it a trial. I'm going to see if I can get through the ICU and this bout of sepsis and require mechanical ventilation. But if it's prolonged, I don't want to. So you have to go at this from an individual role. Harrison, what's the role of nurses in withdrawing and withholding? Very integrated. We have a very robust rapid response system in the province of Ontario that's also funded by the government. And so we teach our rapid response nurses how to have end-of-life conversations. And in some of our partner hospitals across the province, advanced practice nurses actually lead those serious illness conversations about withholding. and why it's not appropriate. The withdrawal of life support, the nurse in the ICU is the person at the bedside providing the drugs by a pump. We have respiratory therapists, and so they would be the one taking the person off the ventilator. The job of the physician at that time is just to make sure that is to discuss with the nurse, make sure the patient is comfortable, discuss with the family that the patient looks comfortable as you withdraw that support. So nurses absolutely are very much integrated in all of this. However, the College of Nurses does not have any separate policy. They rely on what the physician policy is. Did I get, when there is a DNR, okay, I answered that one. Did I get all of the questions? Costs. When there's a DNR, what does entail giving drugs and medications? I think I answered that one.
You've answered all the questions in the chat box. Any other questions, please? I know Prof is quite busy this period, so we won't keep her long.
Well, it's my fault for being late, so if everybody wants to stay on and ask any more questions, keep them coming. Who initiated the legal procedures? So the last version of, let's talk about a couple of legal things. So the final policy that was written where we can withhold CPR was actually a conversation that the current president of the Canadian Critical Care Society, who happens to be in Ottawa, Dr. James Downer, had with the president of the College of Physicians and Surgeons of Ontario, saying this was unconscionable, we were suffering, we had moral distress. And that's how it ended up going. And then we did consultation across the province. Our hospital put in additional work. In terms of the legal procedures for a consent and capacity board hearing, that's initiated by a physician. So the physician has a set number of forms. They first of all have to declare that the patient is not capable of making decisions, so the decision follows to the substitute decision maker. And then they have about 50 pages of chart in which they lay out their argument, and then it's a tribunal hearing with 2 lawyers, and the one I went through was actually another ICU physician who hear both sides of the family, and I will say sometimes the families don't tell the truth. And then all of the documents. And what made our case much stronger was we had an ethicist, their documentation was impeccable. We had multiple ICU physicians saying that we'd had conversations with the family. We were all agreed that we were providing futile care and that this person was suffering. And the use of that word suffering made a huge difference, that we don't want to be people who are suffering when we're providing care. And we all know that we hate to see people suffering. And so that was guidance for futility. This is where I think we have to check our benefits. Can we turn around the underlying disease, first of all? Is the person suffering because they're not able to interact with their family? The example I had of somebody who was in a vegetative state for 8 months. Development of pressure sores, development of recurrent hospital and ICU acquired infections, all examples of suffering. And that, I think, provides some evidence of this might be futile, right? I don't know what other people think about when you think things are futile. Criteria for death. Okay. So has everybody, I'd have to look them up, read the Canadian Journal of Anesthesia probably less than a year ago? And I don't know if Dr. Burns is still on the line. It's her birthday, by the way. My colleague Karen Burns, who was also a past president of the Canadian Critical Care Society. But so we have a set of guidelines that are really international, but Canada has led them. And so it is truly based on brainstem criteria. And so neurological death, or death by neurological criteria, includes absence of pupillary reflexes, absence of oculocephalic reflexes, no response to central pain. They can still have peripheral spinal reflexes, and that's where families need to understand their spinal reflexes. Absence of cough and gag. Those are done generally with 2 physicians with a license at the bedside. And then finally, an apnea test in which the patient has normal thermia, electrolytes are balanced to the best of your ability. And then it is an apnea test done with 5 of PEEP for 15 to 20 minutes, depending on the patient. You entrain oxygen somewhere between 1 to 2 liters, and then you through the ET tube, and we measure gases about every 5 minutes. And when the pH becomes less than 7.2 and the PCO2 rises to greater than 60, having started with new gases, then we declare neurologically dead. If none of those criteria can be met because of confounding factors, then we do a CT angiogram to look for no perfusion. When discussing do not resuscitate, who are the professionals involved? Professionals, usually the intensivists, always. Often we have social workers. We may have a pastor involved with us, ethicist involved with us, the bedside nurse involved with us. But generally it is the physician. Now, we do this trainees. This is probably one of the big learning curves for our trainees, training to be specialists or even more junior house officers. Their comfort with that. I spend about every 2 months, I give a version of this talk to our trainees and get them to feel comfortable saying, you know, this is why we can't do what we do. I think, Harrison, Irene, everybody,
Yeah.
I've gotten to the
Thank
end
you
of the questions
very
again.
much. Thank you very much. When we started, I was on a high pitch. You have a way of calming everybody down with how you speak and allowing us to understand the message you want to deliver. We appreciate you giving
Harrison,
your time.
I hope this is helpful. I hope this is helpful for the Nigerian community, where you may be struggling with some of these issues in the ICU and thinking about this. And I certainly can share the links to our policy and how a bit of the journey where we've gotten, if people would like it. But I think
we sure will appreciate that to enable us plan our own way so that we'll get less issues arising.
Yes, I think that's important. The other thing I would suggest is really consulting with families who have gone through this in the past, because I think that, you know, there are so many opinions. And, you know, I read a book as a young child, and this may be very relevant for this audience. It was about a young girl during the polio pandemic, and you know, we've gone through other pandemics as well. And the title of the book was "And God Says No." And I sometimes use that phrase to say, you know, we do our best work as physicians and critical care physicians. But sometimes we just can't turn that trajectory along. And so on a late Sunday afternoon in Nigeria and a sunny Sunday afternoon in Hamilton, Ontario, I want to thank all of this audience for being here and for listening to me.
Thank you once again, Prof. If there are any other questions we have, we will relay to you probably through your mail.
Yes.
From Dr. Irene. We appreciate you. I'll hand over to the ESCO. Thanks once
Thank
again.
you very much, Dr. Alison. Thank you very much, Prof. We really appreciate this your wonderful presentation. I'm Dr. Jedri once again. On behalf of the President, Intensive Agricultural Care Society of Nigeria, the ESCO members and the whole member of the society, we want to especially appreciate you for your time, despite your very busy schedule, really giving us this opportunity to drink for your well of experience and also to learn. We really appreciate you for this. And we are hoping that when next we call on you, you will be available for us again. Thank you very much.
Thank you, and thank you for your patience as I was able to get on all of the technical issues this afternoon. So thank you very much. I'm grateful for you inviting me to speak.
Thank you. I will call on Mr. President, Dr. Job. Sir.
Thank you very much, the Fox. Thank you. Earlier on, I said thank you very much for hosting us in Vancouver. I know you're more relaxed now. I'm sure you've overcome some of these challenges. You first hosting thousands of persons in Vancouver. Thank you for this lecture. Actually, it's very interesting because we're a new society, a young society that we're trying to learn about the policies on issues like this from those who are experienced, and that will assist us to develop ours as well. We know we have faced so many challenges, but we know that we overcome them gradually. We want to have more of you talk to us on some issues that are very relevant to our practice in Nigeria. Thank you very much. Thank you for coming. Thank you, everyone. Thank you, immediate past president, Professor Bibio Shinaike, Professor Elizabeth Nwaso, Dr. Briggs, Alagbe Briggs, a immediate past president of the Nigerian Society of Anesthetists, and very other senior colleagues who are here with us. I want to invite everyone to plan for Abuja 2026. Dr. Fox, we hope you'll be in Abuja next year to attend our 11th annual general meeting and scientific conference. And then you come to visit us to see how Nigeria looks like. Thank you. Have a nice weekend for everyone.
I would love that invitation to visit Nigeria. It would be wonderful. Thank you. Take care, everyone.
Thank you very much. Thank you so much. Thank you, Dr. Bruns, for joining. She did join, I think, a bit late, but thank you for joining and a happy birthday.
Thank you. Thank you, Dr. Barnes.
I didn't feel at peace accepting this one. I prayed, yet had no peace.
Thank you for the birthday greetings. Take care, everyone. Bye-bye.
Bye. Thank you so much. Dr. Alison, I'm sure we'll get those materials